Support Training Program. Welcome to the Advanced Life Support Training Program for the Red County Fire Department. I am Chris Murphy. I'll be a lecturer today. As a foreword, this presentation is designed for the members of the RCFD of the Red County Roleplay SAMP server. Whilst the information published in this document is aimed at being as valid as possible, the presentation should not substitute a real-world first aid or medical qualification. Yeah. That's just for the recording purposes, so if he releases it, people aren't all like, "Oh, you're trying to teach." Okay, so ALS is very complimentary. You can't do ALS without basic life support. So to be good at doing ALS, you have to be really good at basic life support. When we say basic life support, what do we mean? This is interactive. I will ask you questions. I do expect answers. What do we mean by basic life support?
Gaining vitals, stabilizing victims as best you can, and just knowing your patient's history is all part of basic life support, and that's going to lead to better ALS.
Fantastic. That's correct. It's all about stabilizing your patient. For an ALS practitioner, anatomy and physiology is something you guys need to know a little bit about, and I will go through it like a really brief overview of the important systems after this part. Another important thing I find is that you need to know when you need help and when to ask for help. It's never a bad thing to ask for help. I still ask people for help out on the road. Cool. So the definition of ALS is medical care that extends the skills and protocols of basic life support. My definition of ALS is basic life support with pointy jabby things, putting needles into people, tubes into holes where there shouldn't be tubes, and electrodes on their skin. Fairly simple. A lot of advanced life support is to do with advanced assessment and invasive procedures. Cool. So next page, page 4, anatomy and phys. Terribly boring, but if you want to know ALS, you need to know a little bit. So we'll cover central nervous and peripheral nervous system, cardiovascular system, respiratory system, musculoskeletal system, gastrointestinal system. I may or may not also talk a little about the renal system, depending on how I feel at the end. It's one of those ones that's kind of important, but quite confusing, so I'll see how you guys are feeling, yeah? Cool. CNS, central nervous system, consists of the brain and spinal cord. As you guys would know, the brain is where nerve impulses begin. Made up of 4 lobes, 2 hemispheres, the corpus callosum joins them. So you guys know that there's a crossover of the brain. So left side of your brain causes right-sided movement and stimulation, yeah?
That is something I didn't know.
Ah, there you go. So if a patient, for example, a major example here, if a patient has a right-hand-sided stroke, they'll have left-sided weaknesses or paraplegia. Because there's a mirror when the signals cross the center of the brain. There you go. Someone's patinking me. Jamie. Sorry. There are 5 main parts of the brain. Frontal lobe, which is funny enough at the front. Responsible for conscious thought, mood, social interaction. When people get a head injury, which is quite traumatic, affecting the front of their head, that can cause a lot of mood changes. So people who are generally happy and joking, might become really grumpy and hard to talk to. Car accidents, people often come out of car accidents and their families say they've changed. That's often the reason why. Parietal lobe, which is sort of above, further back to the frontal lobe, is, as I said, crucial for interpretation of sensory information, as well as fine motor skills interaction with objects. So
Hi,
essentially,
Ben. Chris, sorry. I just came
yeah,
back from work.
no worries. We're up to page 4 on the PowerPoint. So essentially, if you touch a hot object, it's the parietal lobe eventually that gets the signal saying, ouch, that's hot. Next, we've got the temporal lobe, which is sort of next to the parietal lobe. It's really hard to describe without pictures. Associated with sound and smell. It's also responsible for processing complex stimuli like faces and facial expressions and sort of recognizing a scene that's happening. So when you're watching a movie, your occipital lobe and your temporal lobe are really communicating a lot because they're trying to interpret what's happening on the screen in terms of the scenes and the faces and the expressions. Yeah. And your occipital lobe does a lot of things in general, but sense of sight is the main thing. The brainstem is quite possibly the most important part of your brain, as it is responsible for the stimulation of those basic functions, consciousness, your heart rate, your respiration, digestion, and pain response. If you happen to get damage to your brainstem or is severed or traumatically damaged, patients will either be very disabled and be on a ventilator or die quite quickly. If you're going to get hit in the brain anywhere, it's not the stem. Location-wise, the brainstem is pretty well hidden. It's sort of up between your first and second vertebrae, in the middle of your neck, at the base of your head, base of skull. So when someone has a base of skull fracture, that's why it's so dangerous, is because it's close to that brainstem. Yeah. The spine comes off the brain, connects to the brainstem. It's a bunch of vertebrae that houses the spinal cord. Spinal cord itself is the branching point for spinal nerves. Probably should have put it on there, but I didn't. There are different sections of the spine.
Chris, could you send me the PowerPoint, please?
It's in the file browser.
Right. Where are we all in the file station right now?
No,
it's not in game. It's
User
only in
left your
TS.
channel.
Alright.
User joined your channel.
The password's wanker, yeah, like you just put in chat.
So yes, the spine is the central sort of branching point for spinal nerves. Now your vertebrae, you know that they're called, they've got different sections of different names, yeah? Does anyone know the names of these vertebrae?
There's a shit ton of them, but I'm not sure what they're called.
There are 5 different sections. Cervical, thoracic, lumbar. Anyone know the other 2? Anyone know the other 2?
Nope.
No? Really?
I'm just EMTB, so
The sacrum and the coccyx, or the sacral curve and the coccyx. So, how do we remember what they do? It's very hard. It's not entirely important in this sense. Anything in the thoracic section of the spine generally controls your upper body. We're on slide 4. Let's have a look at this. Sorry, you're right, 6. Yes, cervical spine, lumbar spine. Correct. That's what we're looking at. So
I
see,
see.
if you have a look at that picture that we've just posted, thank you, Roy. C1 and 2, the atlas and the axis there. Underneath them is your brainstem. Anything between T1, your first thoracic vertebra, and the last one, the spinal nerves generally control anything in your chest and part of your abdomen. So damage along those spines, you're looking at disability and difficulty breathing, things like that.
So
Actually, difficulties breathing up higher, to be honest. Yeah, go ahead.
when you C-spine someone, the board takes care of thoracics to coccyx, and then the cervical spine is obviously taken care of by the cervical collar, I guess. But what does you know the CIDs, the two foam blocks that you put on either
Beside
side
the
of
head?
their head?
Mhm.
Yeah, what do you guys call those?
Head blocks.
Head blocks. Okay,
We call them head blocks.
they used to use sandbags, right?
We
Like,
used to use towels, or we still use towels occasionally. Roll up
okay,
towels.
gotcha. All right, what purpose do they serve?
To attempt to minimize head movement, just the same as manual immobilization.
Gotcha. All right.
Yeah, cool. All right, peripheral nervous system we've sort of covered in terms of the spinal cord, the spinal nerves, the nerves that come off the spinal cord, down to the nerves in your fingertips. Unlike the spinal cord and the brain, they're quite vulnerable because they're not protected by bones, blood-brain barrier and such. Cool. CNS and PNS done. Any questions about the CNS and PNS? No. Brilliant. A fun one. Cardiovascular system on slide 8. It refers to the heart and the blood vessels. So we know there are 3 main kinds of blood vessels, yes?
Yeah.
Yeah.
I'm watching them as we speak.
Excellent. Generally, arteries carry oxygenated blood, veins carry deoxygenated blood. Does anyone know an instance when that's reversed?
An instance where what's reversed?
Anyone know an instance where a vein would carry oxygenated blood and arteries deoxygenated blood?
I know that one vein does that actually.
Which one? Do you know?
Yeah, it's the diagonal vein which actually goes from your heart to your stomach area. I think.
Your stomach?
Yeah, not like the one that passes through. Not sure
Not
how it's called
quite
again.
correct. Not quite correct.
I'm not sure how it's called.
So the pulmonary blood vessels are reversed.
How are they called?
Pulmonary. So they're the blood vessels that go from your heart to your
To your
lungs and
lungs.
back.
So, what are the inferior and superior vena cavas? What are they considered? Veins?
Cool. They're veins. Vena cava's veins. Superior vena
Gotcha.
cava takes the blood from your brain and the top half of your body, and the inferior vena cava from the bottom half.
So, what does your body produces? Obviously, non-oxygenated blood, and then it's oxygenated. Okay, gotcha. All right.
Yeah. So we breathe in. I'll go over a brief overview. We breathe in air. Air goes to our lungs. In our lungs, it goes to the alveoli. In the alveoli, there are capillaries, which facilitate gas exchange. So the deoxygenated blood in those capillaries gives the alveoli their carbon dioxide and takes some oxygen. The blood then moves through the capillaries into the pulmonary vein, where it is then transferred back to the heart, pumped to the rest of the body, oxygenated into tissues, where it is then gas exchange occurs again. Bit of a cycle. Make sense? Ish.
User disconnected from your channel.
Cool. The heart is one of the most amazing organs. I won't get too excited, but I can get excited. It's made up of cardiac muscle, which we'll tell you a bit about later. Please excuse the spelling error on this page. So there are 4 chambers, left and right atria, the left and right ventricles. Who knows where these are? Where are the atria? On top or bottom?
Atria is on top. It's the entrance point and exit point.
Yes, that is correct. So, which side of the heart is responsible for, what am I thinking? Which side of the heart is responsible for
Pulmonary
Yeah, that's what I'm looking for. For
would be,
pulmonary,
would be the right side.
yes, fantastic. So when we have someone who has, for example, right-sided heart failure, what's an issue with that? Do we think?
Would be pulmonic.
Yeah. So essentially, if they've got right-sided heart failure, they're not getting a whole lot of blood back through to the lungs. So their oxygen saturation is going to be low, and they're going to be tired a lot quicker, and there'll be a lot of fluid
User
build up in the lungs.
disconnected from your channel.
So would a right-sided heart issue be more severe than a left-sided, or would it be faster acting, so to speak? Because
Really depends on the extent, and other things going on at that point in time. You can live with both if they're well managed. Right-sided can be more dangerous because it leaves you open for things such as fluid in lungs and things like that. A lot easier. If we look down to...
User joined your channel.
Oops, who came back?
Cody.
Somebody came back. Cody. If we look down to page 10, we can see a little image I've stolen from Wikipedia, which is actually a really easy way of seeing sort of where the blood goes in the heart.
Yeah, I'm there. You can go, you can continue.
what page?
10.
10. Cool.
Yeah, they missed the mitral valve in their little flowchart.
Yeah, they just haven't added it. They also missed the bicuspid valve. Okay, respiratory system. First the breathing and taking in oxygen and air and things like that. So there are two types of respiration. And no, it's not breathing in and breathing out. External respiration is what we all refer to as breathing. It's where air is taken from the atmosphere into our lungs, and we breathe out carbon dioxide. Easiest function. Internal respiration is a sort of very cellular level metabolic function in which the oxygen is released into tissue and carbon dioxide is taken into the blood. Got that?
Yep.
Cool. So how does breathing work? Do you guys actually know that without looking at the slide? Why we breathe in?
To get
Yeah.
oxygen.
Oxygen to our
Get ox-
muscles, brain,
Mhm.
basically every
physiologically,
organ.
what
Well, not really
physiologically what
every.
makes us breathe? What makes us breathe physiologically? How does it work? Anyone know?
Muscles.
Yeah, the muscles
Muscles.
around the lungs. No?
Actually, no. It's
No.
it's the muscles below the lungs.
You're right. It's the one muscle below the lung, the diaphragm, generally. This will explain to you how a pneumothorax works. If there is an air leak, you get air in the space between the lung and the chest wall. Yeah.
Yes.
Yep. So external respiration occurs because when your diaphragm contracts, it pulls down, stretching those lungs out, creating more space for air to come in, which then causes you to breathe in and the air actually gets taken into the lungs. When you breathe out, the diaphragm relaxes, the lungs squash up again, and the air is forced out. So if you can imagine that there's a hole in one of your lungs and the air's leaking into a chest wall, there's a huge, huge, huge space there going on there. So the vacuum effect is like doubled in the wrong spot, yeah?
Yeah, where's the largest? That would be the chest cavity, right?
Yeah, the
That's
chest
like
cavity.
the largest area in your heart, in your body, rather.
If you took all the organs out, it'd be pretty close between the abdomen and the chest cavity. So whilst the diaphragm is the majority of air movement, like we said, there are other muscles that may at times be used. So we said the muscles around the lungs, so the intercostal muscles, which are in between. A tracheal tug is seen when you have some sort of severe difficulty breathing. Essentially, the function of the tracheal tug is actually the muscles around the trachea are trying to force air down it. The other two there are sort of my areas because I work in pediatrics. Subcostal and substernal are very, very rare in adults. If you see them, they're really, really working hard, but they are quite common in babies with respiratory distress. Respiratory system covered? Any questions?
Pretty clear.
Clear?
How much
Cool.
blood can an adult lose in the case of a hemothorax?
Sorry?
How much blood loss can you experience in the case of a hemothorax?
As in how much can you physically lose, or
Like what percentage do you know? Like,
I don't know what percentage you can lose. I would say it would keep going until it was full, or the patient died.
Well, I've
Gotcha.
got a little question. When you're actually
Yes.
applying chest needle decompression, right?
Mhm.
That's like at the third rib, right?
Second.
The second, between the second and the third,
Second.
right? And
Yes.
is there any other place where you could do that?
Which would
The
be
sorry. Go ahead, Roy.
that would be the second intercostal space, right? Second, third
Yeah,
rib.
second intercostal space.
Gotcha.
There are other places you can do it, but then it becomes a bit more difficult in terms of placement without imaging, such as an X-ray and a CT. That's why they sort of go second intercostal space because it's quite easily identifiable, and it's also a reasonably large area. So if one doesn't do it, you can do more laterally, keep going across.
All right.
Yeah. If you go too low, you'll puncture the heart. If you go too high, you won't get much lung.
All
Cool.
right.
All right, musculoskeletal. 3 types of muscle. Skeletal is the most common, the one you sort of all know about. It's it's always used for voluntary movement. and occasionally for involuntary, so the diaphragm is also skeletal muscle. It's the one that has the opposing force. You know, you lift your arm, one muscle contracts, one relaxes, yeah? Smooth muscle is only seen in involuntary movement. So movements that we don't think about and control. Your stomach, your esophagus, your large and
Lungs?
small bowel are all,
No
are all
lungs?
um, I
I think
don't
they
think
could.
they're muscle. No, they're not. They're tissue. They're sorry, they're a tissue.
They're like the
Yes.
pure spongy. Okay.
Yeah. You had to be down for a second there. It's like, oh, no. Yeah, so you'll see smooth muscle in hollow organs, essentially. And the cardiac muscle is very, very special. Very special. It's only seen in the heart, funnily enough for its name, and it has what we call pacemaking ability. So,
Unbalanced resting membrane potential.
sorry?
You're not going to go into resting membrane potential, are you?
Oh god, no. I consider doing acid-base balance. No. Essentially, where muscles require the brain to say move or innervation, cardiac muscle doesn't. It actually has the ability to send off a spark to itself and make itself contract or pump. Unfortunately, it can't regulate itself. It does still need the brain to say beat now, beat now, beat now. But without the brain, it can just beat.
All right. So,
Yeah, it's quite
in
amazing.
fact, if you're brain dead, you actually um still be able to actually make some beats with your heart.
Yes, they
All
won't be
right.
effective, it won't be enough to sustain you, but the heart itself will beat
Alright.
until it receives no blood flow and then dies. So
Pretty weird.
it's quite strange. There's actually, if you look at a deceased patient on an ECG monitor, not long after they've died, there's what's called a dying heart rhythm. So you guys see a flat line. 5 minutes later, you might see a bit of an elevation, which is where that there's the SA notice firing off. Sort of another last little beat going on. A little bit freaky at times, yeah. I remember one of my first resusces, we had him on the monitor, well, the first failed one, had him on the monitor and, sort of packing up afterwards and sort of consoling the family. And one of the kids points at the monitor and goes, "Look." We turn around and sure enough, there's this dying heart rhythm and it does it again. And we're like, shit. Get down, stethoscope out and check it out. But no, it was actually just a dying heart rhythm. Yeah, it was actually deceased, unfortunately.
Wow.
Alright, skeleton. Classified into two parts. As my bad spelling says there, parts. The axial, the axial and the appendicular. Don't expect you to remember that, just for the fun of it. It's easy to remember. Axial being the axis, up and down the middle. Skull, vertebra, and pelvis. Appendicular, everything else hanging off it. 4 types of bone. The long bone, the short bone, the flat, and the irregular. Long bone does, yes, include things like the radius and the ulnar in your arms. Which bones are we most likely to fracture, do you guys think?
Short bones. No, long bones, sorry.
Long bones, yeah. Long bones and occasionally irregular bones. So the pelvis is an irregular bone. Short bones are very difficult to fracture because they're generally quite small. And flat bones are generally quite solid, so they're hard to fracture.
Well, we don't really have much flat skulls. I mean, flat bones.
No, most of it's in the skull, yeah. Okie dokie. Gastrointestinal tube. Tract. Gastrointestinal tract is essentially a long tube. Goes from your mouth to your bum. It does have little bits hanging off of auxiliary organs. The whole system itself is sort of responsible for absorbing nutrients from your food and then translating that into something usable for the body. So, page 16. I'll give you a quick overview of what happens when you eat. Put something in your mouth, you start chewing it. There are some enzymes in your mouth that begin the breakdown of the food, but most of it's mechanical. So your chewing helps break down that food. You swallow it down your esophagus. It moves down with a motion called peristalsis, which is actually like a rhythmic wave sort of formation. If you find an animation on the internet, it's really cool to look at. But essentially it pushes little balls or boluses of food down the esophagus. In the stomach, you run into bile and enzymes that help digest it. The small intestine is where a lot of the nutrients are taken out. And it passes through the small intestine to the large intestine, where a lot of the water is taken out. And that's where your poo is formed, which is then expelled into the toilet via your rectum, unless you have a colostomy bag. Found one?
Yep.
Peristalsis. Let's have a look. This is a good website. DNA tube. Not working. There we go. Oh, I don't want to listen to you. Yeah. So that's Paracelsus. So, so the auxiliary organs in the gastrointestinal systems are not directly connected to the tube, but do help with it. You got your pancreas, which creates the insulin, which allows glucose into the cells. Gallbladder, which you can live without, stores bile to be later used. Note it only stores bile, the liver actually creates it. Gallstones are quite common. They often present similar to a heart attack. Very, very painful. Cool.
Hang on, are we still talking about the digestive system? Or...
Yes, these are the auxiliary organs of it.
Oh yeah, okay.
Yeah, so they're not directly involved in digestion. Yeah, any questions about gastrointestinal?
Not really, no.
So if you have a perforated bowel, so you receive an injury to the stomach, the abdomen area, and it causes a breach in your large intestine, why do we think that might be sort of dangerous?
Ooh, it's gonna be a hard one. Because of the, I don't know,
Lose
the
a lot of
fluids.
blood.
Not so much blood.
I
While they're
think
vascular organs, they're not that vascular.
I think actually the acids that come from it. I don't know. Your
The which way?
stomach.
The acids?
Yeah.
Uh, I'm talking more about the large intestine. The stomach's actually quite small compared to the intestines.
All right.
Think about what's created in the large intestines.
Poo.
Poo, yeah. So what is poo?
It's
Bacteria.
the remains
it's
of your
bacteria.
food, to be honest. Yeah, there is.
It's the remains of the stuff that we don't want, the stuff that the body wants to expel. So if you imagine that getting out into sort of your peritoneum, the inside of your abdomen, where it can sort of get into other organs and other tissue.
Sepsis.
Sepsis, yeah. One of the biggest causes of sepsis is a ruptured bowel. Funnily enough, I worked at a hospital once, not that long ago, for a couple of shifts, where they had a lot of patients who ended up having colonoscopy, so they had a camera up their bum. And for some reason, there was one surgeon who wasn't very good at it, and he kept perforating their bowels. Fortunately, none of his patients got septic. But yes, it was quite funny because every time we had a patient come out perf post colonoscopy, we went, "Ooh, was that Willerman?" And they went, "Yes."
That's terrible. Did they fire him?
I don't think so.
Oh my god.
I only did a couple of shifts there, 4 or 5 shifts there.
Okay.
Do we want to talk about the renal system, so the kidneys?
Yeah, actually do.
Cool. So, who knows what the kidneys do? Anyone, any idea what they do?
They are actually filtering your the junk out of your blood. You can
Brilliant.
say, actually.
Yeah, they do. That's correct. They yeah, they filter stuff out of your blood and create wee.
I call it
Anyone have any
dialysis,
idea?
right?
Dialysis, yeah.
Dialysis, yeah.
If you don't have proper kidneys, you need dialysis. Does anyone know how the kidneys might function and might affect blood pressure?
If they don't work good and the blood actually misses a good part of the filtering, then the veins will get too much pressure as they pass the pretty most important part of the blood filtering.
No, not really. You don't. This isn't necessary for you to know, but for your information, it's quite interesting. There's a system in the kidneys called the renin-angiotensin-aldosterone system. So there are three sort of hormones that cause different things to happen. Essentially, the renin is released. It causes the angiotensin to turn from angiotensin 1 to angiotensin 2, which causes aldosterone to be released. Don't have to worry about that. What it does is it the kidneys turn around and say, oh, look, I'm getting all this volume coming through. I need to loosen up these blood vessels to drop this blood pressure. So it begins saying, don't really need a whole lot of fluid, so I'll start weeing more fluid. To do that, it also says, I've got a lot of sodium in me too, and that sort of is keeping the fluid in me. So it starts putting sodium out too. And works in the opposite direction for a low blood pressure.
Is there actually a IV medication that you actually could prevent the high blood pressure from?
Yeah, heaps of medications that can sort of decrease blood pressure. In terms of IV medications for emergency,
Rapamil?
Verapamil, yes. Just trying to think of the other name for it. I like Lasix. Excuse me. Doesn't doesn't actually sort of directly affect the blood pressure. It causes the kidneys to pee more, to filter more and output more.
Alright.
Increases the fluid output. But yes, Verapamil is probably. I'm sure that's on your list. Is that on your list?
It should be.
Possibly not. Verapamil. It's not. Okay. I'll add that one for the next one.
Make sure you fix Narcan SIRS.
Yes, I shall. Also, if you found a few other mistakes in it too. If you go down to procedures or trauma. Actually, all the procedures turn around and say, after intubation, if failed intubation, 3 times use LMA. And then if you look at trauma, under each section, where's it gone? Oh, where'd it go? Yeah, after the hemopneumothorax, all of the grey headings say hemopneumothorax. So that's me copying and pasting and not reading what I'm doing. They will be rectified. Alright, onto the stuff. Primary assessment. Okay, this should take no longer than 3 minutes and can be done when you're approaching a patient. You could actually do most of this without touching a patient. So how might we know if the patient's airway is patent?
If they can speak.
Fantastic. How can we know if they're breathing adequately?
Symmetrical chest rise and fall.
Yeah, chest rise and fall. How can we tell if they've got adequate circulation?
Pulse.
Without touching them.
Color of the skin.
Yes, beautiful.
Yeah, colour of the skin, white parts of the body, less blood.
Great, that's fantastic. Cool, so say you walk up to a patient, they're looking a little bit on the blue side, they're slumped in a chair with their head forward. What do we do? What's your first thing to do?
Check if anything is blocking their airway from breathing.
Beautiful, so the head is slumped forward.
Get them in the
Exactly.
supine position. Or
You could
get their...
supine.
Well, if their head is actually bending forward, actually the throat could be blocking the airway by the
Yep.
head hanging forward, so actually we would move the head backwards so the airway is
Beautiful,
open.
head tilt. Open the airway with a head tilt. Cool. Remember how I said ALS is quite invasive? We want to minimise the amount of things we invade the patient's body with. While they might all be helpful for us, they can actually be quite harmful for the patient in terms of infection later, and quite uncomfortable. So if you don't need to put a tube down a patient's throat, don't. That's a general adage I go with. Road. So if the patient's not breathing, we can assist ventilation. Sometimes all it takes is a head tilt to make a patient breathe. Other times you will need to whack a BVM on them and start manually ventilating them. I'm sitting here actually squeezing my hand as if I was ventilating a patient. That's fun. Circulation. How can we sort of fix up circulation if you've got circulatory issues?
How do you mean?
What can we do?
CPR.
The patient has a pulse rate. They're still breathing adequately, but they're looking really, really pale. But you can't see any sign of external bleeding. What's something you might be able to do as an ALS medic? What's something you could do?
Give them fluids.
Yes, initiate IV fluids. Beautiful. Circulation has a lot to do with fluid replacement and bleeding, as well as compressions. If your patient's unconscious and not breathing, circulation becomes compressions. If they're conscious, if they're breathing, it becomes fluid related. Disability is you assess the consciousness level, orientation, using the AVPU method or GCS, and then you look at sort of head injury assessment and things like that. Some people also throw blood sugars into D, partly because people who have a low or high blood sugar can get quite confused. But it's not something we come across a lot in game. Exposure, it just refers to ensuring you expose all parts of the body as necessary as suitable, and then manage what injuries you find as required. Just remember that your patient does have their own dignity, even if they are unconscious and half dead on the side of the road. If you can move them somewhere private, do so. If you can't, try and create as much privacy by, having someone hold a blanket or something.
What would you like to see in terms of using the seat collar? Because I use it for any kind of traumatic injury.
Yes.
To the spine or neck. Like if somebody's in a like I've seen it before where Dan's the biggest culprit with this. If they're not complaining of neck injury, he'll tell us not to see spine, and I'm like,
I
do it anyway.
Personally, I think you should, because if the spine cadaver actually had a bump, you should actually see color everyone that has the risk of getting a spinal injury.
That's what I do. Like anyway, like any car scene, even if they're not complaining of neck pain, I still see spine.
So, me too.
I don't know what it's like in the States, but down here, our protocols in terms of immobilizing a spine is if they're in a car accident that's going greater than 30 kilometers an hour, if they're in a car accident where the vehicle's rolled, a car accident where a patient has been ejected, a car accident where a patient has died in the vehicle, a fall from greater than 2 meters or standing height, a high-speed deceleration, so they've hit something really fast and stopped really slow, or any other patient that we feel is necessary for immobilization.
That's pretty much how it is here. They see spine all the time.
So I generally see spine in any trauma case I come across, just because there is a potential for spinal injury. And look, you'll never ever be bagged out in real life for rocking up to a hospital with a patient in a collar, unless they're like a medical patient. For a trauma patient, if they rock up with a collar, you won't be told off. When I work in the hospital, it is quite irritating to see paramedics, and being in my position, I know that they should have collared a certain patient, and they haven't. It is really irritating seeing them come in not collared, because then we have to collar them in the hospital anyway, until we can clear that spine.
Considering they were just driving.
Exactly, yeah. Another thing I don't see you guys doing in game, which is something that we do down here, I'm not sure if it's States, is we have a degree of driving for spinal injuries where the lights, I don't do it because I don't drive an ambulance, I drive a car. They have the lights flashing, but they drive slowly. So they sit about 20 k's below the speed limit.
Oh, wow.
Just to sort of maintain a bit of stability. Quite annoying if you're sitting behind them.
The other thing I see people doing is like just basic scene safety. Like I pulled up on a scene where they were in the right-hand lane of traffic and they were just standing there, and they had ambulance was parked on the other side of the road on the shoulder, and I moved his ambulance and put it in the lane, blocking the lane. Like just basic stuff like that irritates me.
That should be covered in your MVA training and stuff like that.
Yeah, literally when you're just standing on the side of the road. I was pissed. But I didn't want to yell at a lieutenant because that'd be a bad thing.
Beautiful. All right, page 18. We're looking at the Glasgow Coma Scale. It's a chart that I nicked from a website. I should have referenced it, but I can't remember where it was from, so we won't tell anybody. GCS is quite hard to sort of master and assess in real life. In game, it's not too bad. Anything below a 9, GCS of 9, requires intubation. They're considered unable to maintain their own airway, and you should put something in to help with that, whether it be an LMA, a laryngeal mask airway, or an endotracheal tube. Anything less than 13 probably should be collared and assessed for head injury, or any point in treatment where a GCS drops more than 2 points, you need to reassess everything again. Make sense?
Yeah.
Yep.
Cool. So I know a lot of this is basic stuff. We will get into more of the procedures in a second. But like I said, you've got to know your basics to actually be good at your advanced stuff. Vital signs. I haven't bothered to put a chart of normal vital sign ranges on, just because it is quite confusing, a lot of you to remember, and people generally don't know them. So you do your normal high-low sort of thing. Vital signs are very important. I like to do at least one set on every patient in-game. I do many, many, many of them in real life. Your first set is known as your baseline. Any deviation from this will tell you what's going on with your patient, whether it be deterioration or your treatment working. When I say vital signs, I'm talking heart rate, respirate rate, pulse oximetry, which is your SpO2, your finger thing with the blood, oxygen level in the blood, your blood pressure and your temperature. Saturations, that's the word. Blood pressure and temperature. You can also throw blood sugar level in there if you're keen. Mind you, not all vitals need to be measured at all times. The imperative ones are heart rate, respirate, and blood pressure. Cool. Cool. Any case that has a respiratory system involvement should have a respiratory status assessment conducted. This involves looking at your patient, how they're sitting or presenting. So if they're sitting, leaning forward, hands on their knees, what we call tripoding, they're trying to give themselves the biggest lung expansion to get more air in. If they're lying on the ground unconscious, it's also not a good thing. Appearance, how do they look? Do they look sweaty? Do they look unsettled? Or do they look quite calm and relaxed? Sounds, can you hear any wheezes without a stethoscope? Can you hear one with a stethoscope? Do you guys know the difference between a wheeze and a stridor?
What's a
Between
roll?
what?
A wheeze and a stridor. Excuse me. So a wheeze is generally comes lower. Stridor sort of higher.
What's a roll?
A what? Sorry.
Rail or roll?
A rail. Oh, that's a really weird sound. How do I explain that?
Like crackles or?
Oh, it's similar to crackles. I'll come back to
Here's
it.
a recording.
Oh, yeah, give me a recording of it. It's similar to crackles, but it's not. It's. Yeah, so they're crackles. Rails tend to be quite fine, like a lot finer
Okay.
and more rattly. It's, respiratory sounds are quite hard to define without listening to them. Effort. Is there any use of those accessory muscles? So those intercostal muscles we talked about in the tracheal tug. And can you see them actually working hard to get breath in? Have a look at their skin. Are they sweating? Are they blue? Are they pale? What's their pulse doing? Increased pulse will mean increased work of breathing. The heart is beating faster to get what oxygen it can around as much as possible. And their state of consciousness. If they're unconscious, it's a pretty good indication that their respiratory system isn't working great. Cool. Now we get to the fun stuff. Alright. In this section, I haven't actually given you the how to do the procedure. It's more about the procedure. The how to do is in the SOPs, which I presume you guys have read over. IV cannulation is used to administer drugs directly into the bloodstream. So you got to remember with this, these drugs go into the bloodstream, and the actions occur pretty much instantly. So if you're putting in, you can't take it out. So you got to be really sure about what dose you're giving. So they're 100% bioavailable, which means that all of the drug is available as soon as you put it in.
Like
Cannula
nothing will
must...
be lost.
Yeah, essentially. So when you swallow a tablet, it goes down to your stomach, and then it gets digested, and then it gets taken into your bloodstream and through. Yeah. So initially, sorry, when you swallow that tablet, say there's 100 milligrams in there of
Aspirin?
we'll say it's 100 milligrams of aspirin. So you swallow 100 milligrams of aspirin. By the time it gets to your bloodstream, there might only be 60% of the aspirin actually left for your heart to, for your bloodstream and your body to use. So that's bioavailability.
But okay, so how much is the decrease actually? So if you actually put it in via your mouth and then goes digestive into your stomach, but what if you put it in anal?
It actually depends on the drugs. Each drug has a different bioavailability. There is sort of a general range as to how much they decrease, but again, it's different drugs. So oral drugs they lose about 40%. Rectal drugs lose about 20%. IV maybe 1%. IO potentially 1% as well. IM you're looking maybe 10. Subcut 15-ish.
All right.
Funnily enough, do you guys know paracetamol or acetaminophen?
Yeah.
Yeah.
Tylenol. Yep. You guys take it orally?
Yeah. Well,
Today,
nowadays I am, but like when I was younger, I was taking it anally from my mom when I was sick.
Rectally is actually more effective and is actually uptaken a lot quicker.
Yep.
Yum.
Not comfortable,
I know.
but it is, yeah. And you're right, it's actually commonly used in children. It's a lot easier to get them to put it up their bum and swallow it. And it's a different tablet, it's not the same tablet. Just so you guys know.
Suppository.
Yeah.
Like
You just told us not to stick Tylenol per ass, didn't you?
like anal thingies that have like
Analgesia.
a more dildo-ish form. Dildo-ish size. It's true, Jesus.
Oh god.
You certainly had a fine childhood.
What the hell? Oh jeez.
By the way, I have to go, so could you send me the URL and
For the...
in PM or something on the forums?
Yes, I'll send you a forum PM of the...
Thank you. I'll ask Jack for the recording.
Okie dokie. So, this is what a suppository looks like.
Let me check that real quick. I see.
Oh,
Yeah, that's
lovely.
what I told you. It's like they've got more like bullet size, you know.
User
Dude, I'm not even
disconnected from
kidding.
your channel.
They do.
They are not fun to give.
I know.
All right. So once we've cannulated our patient, we must swab and flush the cannula. We also flush that cannula after every drug, or in between drugs. So the flush, what it does is it pushes any drug that's currently in the tube, in the cannula, out of it. So there isn't any drug mixing and possible reactions with drugs. Some drugs, if you mix them, react quite badly, and they can... There's actually 2 antibiotics, if you mix them, they create salt.
Just from my knowledge, right? Saline contains all vitamins that blood contains as well, right?
Saline? No. Saline contains sodium, a little bit of sodium.
Alright. So it's actually
One
just water
you're...
with sodium and then...
Yeah.
Okay.
The one you're thinking of is either Ringers or Hartmann's,
Alright.
which contains little bits and pieces.
You
How
can't
about-
you can't
how-
give lactated ringers to people with what is it, kidney failure, or I forget what it is.
It's you're not supposed to, but they generally can handle it if they're sort of dialyzing regularly.
How about D50?
D50 is in terms of what, renal patients.
Dextrose 50%, like the fluid.
Yeah, yeah. Are you talking about giving it to people with kidney failure?
Oh, not really, but like
Oh.
is it close to the stuff that I was how was it called again?
Oh
Just
no,
named?
it's essentially all glucose in some fluid.
Alright.
D50 is not. Yeah. If you give somebody D50, they don't know, their blood pressure's going to shoot through the blood sugar's going to shoot through the roof.
Alright.
Good question. They're good questions. So on your list of drugs in your SOPs, there are 3 fluids I've put in there for fluid replacement. I've also put D50 and a couple of blood products. The
Is it?
3 on the SOPs, I think it's, I don't know, they're on there in various pages.
You've got it here. Using a 1 litre bag of normal saline, Hartmann's or Ringers.
That's it.
Fluid rehydration.
That's it. We'll go to intraosseous. Is becoming more popular in pre-hospital settings now. It was sort of traditionally only used for children, like babies. It's now used for trauma patients a lot, particularly when IV's access isn't available. Has the same bioavailability as IV patients, as IV drugs, and is extremely painful for the patient. You're getting a needle drilled into a bone.
Oh yeah. I know that.
Otherwise, it's the same procedure as giving fluids or drugs via IV.
Is it
I do
able to actually do that in a emergency situation? Just like
give
as
IO?
quick as IV? Yeah?
Yes. It's actually a bit quicker to do an IO injection, an IO cannulation.
So
Just because they sort of...
you would mainly actually do that with people that are unconscious or
No.
trauma patients, as you just said.
Go IO. Sorry, only go IO if you can't get IV. That's general rule. Based on the pain level and the risk of infection, bone infections are really bad, which is sort of why IO isn't done more commonly. IV infections can be managed with antibiotics quite effectively if you get on top of them quickly. Bone infections are very hard to manage. But if you get a trauma patient with both arms cut off and you can't find a vein in their legs, go IO.
Or an addict.
Or an IV drug user who has just destroyed their veins. You have to go IO.
Like that?
It'd be the tibia, but proximal tibia. But what's the other location? What's the other location you were saying?
I've said proximal tibia and also sternal. Superior sternal. which I believe I've marked out on your procedures section in the SOPs.
If
Sure,
you
put a
go
picture.
if you go IO, you should actually go tibia always, because that's a hollow bone, isn't it? I mean, no, it's not a hollow bone, but it's
It's
got
just a
like
larger bone and it's flatter.
yeah.
It's larger, yeah. Although the sternum is also the top of the sternum is quite accessible too.
You
You
need a
don't want to
longer
be giving
needle
an
for that,
IO.
don't you?
Sorry,
You need a longer IO needle for the sternum, don't
you
you?
need small. You need smaller IO needle
Oh,
for the
gotcha.
sternum. You don't want to be going for the legs, for the tibia, if the patient has a fracture in that
I
leg.
heard you could do it in the arm.
Yeah,
Sometimes.
you can. Same places you do an IM injection in the arm, but I thought I'll give you 3 places because 3 is a nice number. And quite often, um, the arms are quite difficult to cannulate with an IO because of the location's a round ball. If it slips, cause a lot of pain, and you
Gotcha.
miss. Start again. Yeah. Cool. So IO done. Fluid rehydration. We use, as we said, we figured out, so saline, Hartmann, and ringers. It's a pretty simple procedure. You take your bag, you spike it with a giving set or IV tubing, prime the line, which eliminates any air from the tubing. You swab the bung, attach the primed line, open the clamp and run the fluids. In the hospital we have pumps and we set limits and drip rates. In the field or in ED, you've got 2 drip rates, really, really fast or really, really slow.
Right, and that's like the only things you have, or
Um, it's just because it is a pain in the ass to set drip rates
yeah, okay.
without a pump. When I start trauma care, there will be the air ambulance will have a pump in it, but that's for other reasons. When on the road, if they're in need of rehydration, open the clamp wide open. Cool.
Fluid camp is just yeah, right, yeah, never mind, got it. Yep.
If I mention something about KVO or TKVO, that means run it slowly. It just says to keep vein open. Essentially, it stops the cannula from becoming clotted.
So, running NSIV TKO would be a slower drip rate of NSIV, right?
Yeah, just you just open the clamp enough for it to still be dripping.
Gotcha.
Yeah. Okie dokie, intubation. It's an artificial tube in the airway to help it be maintained. That's not all of the indications I've written there. There are definitely more indications, but they're the common ones. Airway burns are big ones. Patients may come to you and they'll be breathing fine, but organic obstruction can occur when smoke sort of irritates tracheal tissue, and they can swell up. Cool. All your procedures in terms of rapid sequence and pharmacologically assisted intubation are in the protocols. As I said, this is just sort of an overview. Use either the laryngoscope, use a Macintosh blade for adults. You'll rarely use a Miller or a flat, straight blade for adults. I only use them on babies.
You know, the thing that I find weird is that
Mhm.
you're actually inflating the coughs with saline, not with
Mhm.
air. How's that?
How's that? That's an Australian thing, I think. Americans like to do air.
Yeah, US is there.
This
Yeah,
comes from my
same. Netherlands
this
is
comes from
air as
my
well.
nursing background. Air sort of different pressures can make air decrease and expand and all that, and you can cause potential trauma. Also, if the tube's in for a long period of time, it can decrease in volume, air volume, whereas saline's less likely to decrease in volume and alters too much of the pressures.
Oh, yeah, that makes sense.
That's what I've been taught. That's the thinking behind it.
Well, that makes sense if you go think about it.
Yeah. Look, whether you guys want to put air or sail on it in game, I don't mind.
Alright.
So, confirmation of placement in a hospital, we generally do a bit of an X-ray. Can't do that on an ambulance, clearly. So you do some capnography. Bye-bye. We do some capnography, which we look at the carbon dioxide expired, which is sort of the gold standard auscultation for bilateral breath sounds. So you put your stethoscope to their chest while you're pumping a bit of air through, and make sure you hear it on both sides. It's the more common and more accepted, more common and more widely used confirmation.
What's the
Cool.
laryngeal mask airway, actually?
Well, that is on the next page.
Oh, seriously?
Cool.
Seriously.
If your patient begins to gag or you think you've placed the tube incorrectly, pull it out, try again. After three attempts, revert to an LMA, laryngeal mask airway.
It's a blind
These
insertion,
buggers-
correct?
Yeah, these buggers
Gotcha.
are dead easy to put in. These are fantastic. Yep, that's one there. The actual mask bit comes deflated, so you can actually get it in a lot easier. And that one you push air into.
Not Taily?
That's an ET tube, and
No.
then the first link's an LMA, and the second link's an ET tube. ET tube would be with the laryngoscope, and then the LMA is blind insertion.
Fantastic. And the size you've got there, the 7.5 millimeters, are the most common size for adults.
So actually, that air part would actually block your airway from any fluids that could obstruct the intubation process.
Essentially, and it holds the tube in place in the airway. You also secure it with tape or something as well. So if you're looking at the ET tube, the inflated bit at the far left, when you get it, isn't inflated, it's actually flush with the tube. So they've pushed either air or it looks like air into it to inflate that tube. Inflate that cuff.
Do you guys have king or salt airways down there?
We do. We don't use them a lot, honestly. We just go ET or LMA. We might occasionally use a combo tube.
Gotcha. Right.
Maybe. But yeah, we're sort of moving away from them, more favouring LMAs based on ease of access.
Combi tubes, blind insert, right? With the two lumens and the distal and proximal cuff and all that bullshit. I can see why LMA would be. I can see why LMA would be. Yeah.
You just jam that bugger in. It's pretty hard to get it wrong.
So in fact, actually, the LMA has just a bigger cuff than the ET tube. That's the only difference, right?
Yes and no. The mask bit, you see at the end, the white bit there, it sits just above the trachea. So where your pharynx splits into the esophagus and your trachea, it sits there and it holds the esophagus shut.
Alright, so that part actually is in your throat.
Yeah.
Mm-hmm.
Alright.
It doesn't go quite as far as an endotracheal tube.
Alright.
Okay, electrocardiography. ALS medics are expected to use a 12-lead ECG. It's always confused me. Yeah, that's an LMA. It's always confused me as to why they're actually called a 12-lead ECG when they only have 10 leads. It should be called it's called this because it looks at 12 different axes of the heart. Essentially, I don't expect you to know all of them. I honestly don't know all of them. I generally look at a couple of leads and see whether they're normal or not.
Lead 2 is the most common to use, right?
Lead 2 is the most important and most common. Because it gives you the whole view. I don't expect you to know where to put these leads. Okay, that's just an indication of sort of where they go, just for your knowledge. You don't need to sort of RP that. Just as long as you say, /me applies the 10 leads to the patient's chest. That's fine. Cool. interpreting an ECG or EKG, whatever you want to call it. So, normal ECG, you should be able to see a P wave, a QRS complex or segment, and a T wave. I've sort of really simplified essentially what each of those waves and segments mean. That's a really simplified version of what they mean.
Which are really cool, really easy animation to look at.
Yeah, this is actually a good one.
It gives the physiology and the ECG underneath.
Yeah. So the first little dot you see firing off the SA node at the top left goes down to the atrioventricular node, which then spreads down to the Purkinje fibers. Yeah. PQRST. It's all also the electrical activity of the heart.
You see, P wave is the firing of the AV node and the atrium's contracting and then or
Yep.
depolarizing rather.
It's
And then-
depolarizing.
And then the
Chris, is that-
QRS complex.
Sorry.
What the fuck is that?
It's a pager, I think.
And then QRS complex is
It's a rapid contraction of the ventricles, essentially pushing the blood out.
you'll
And
never
depolarizing.
see and the what the T wave is repolarization of the
Mhm.
ventricles, and you'll never see repolarization of the atriums on an ECG. You'll only see the ventricles.
No, you'd take a lot to see a repolarization of the atrium. You may also not see a T wave sometimes. Some people you just don't see a T wave on.
Really?
Yeah, very occasionally.
Huh.
So you base it on other things. So you look at this isoelectric baseline if it follows that, and your morphology and things like that. Again, I don't expect you to know how to identify all these rhythms. These are just for your more information. So this is a normal size rhythm. This is a normal rhythm. You can see a P wave before the QRS, a QRS complex, and a T wave. It's pretty regular, and it follows an isoelectric baseline. If you look at atrial fibrillation, the P wave and the T wave aren't visible, but you can see the QRS complex. But it also maintains that baseline,
Back. Sorry.
which essentially says that the AV node is still getting that message, that activity. VT is a pain in the ass. It just looks like a bastard. It's what we call irregular morphology. While it is regular per se, it is irregular because there is sort of no discernible complexes or waves. VF, again, is chaotic morphology because it's the AV node firing chaotically. So the heart isn't pumping anything properly. As opposed to the VT where the heart is pumping properly but really, 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 really fast. A STEMI, or an ST elevation myocardial infarction, or a heart attack. If you look at the little arrow there's an elevation between the S part and the T wave. You'll sort of see that if the patient's sort of having a heart attack in front of you.
So actually, that part is showing that that one part of the heart isn't getting a a shock actually, not a shock,
Brilliant.
but electric pulse.
Brilliant. Yes. What that is showing here, like you said, is that part of the heart is dying and isn't receiving that electricity, so it's finding a way around it.
Yeah.
That's fantastic. Good. And an NSTEMI is sort of something you'll see generally after a sort of a heart attack. You can't see it during. This is generally after a heart attack. Similar thing. Trying to find a way around. Cool. ECG sort of covered. ECG sort of covered. All right, chest needle decompression. So we do this for a suspected pneumothorax, a suspected hemothorax, or a hemopneumothorax, or a tension pneumothorax. It's the insertion of a large bore needle or chest dart, generally a 14 gauge, into the second intercostal space, down the mid-clavicular line, down the middle of the right, that side of the chest, essentially. Pop it in. If there's no relief, whack another one in. What sort of things can indicate to you that there's relief from this pneumothorax?
Assisting from the gauge needle.
Yep. What else?
It'd be easier for the victim to breathe, obviously.
Yeah, easier breathing.
Sometimes a bit of fluids can come out.
Bit of fluid, yeah. Also, if you have a look at the trachea, you can often see that it is skewed to one side because that's the way it's being pulled. That's pretty cool. So that'll sort of come back to the center-ish. That's how we do it. That's all
Can
the
you explain
procedures.
what pneumothorax, hemothorax, and hemopneumothorax is actually? I don't
Okay,
really know the
pneumothorax.
difference between those.
Pneumothorax, pneumo meaning air, is air in the thoracic space between the lung and the chest wall.
Yeah.
Hemo being blood, is blood in that space. A
Alright.
hemopneumothorax is blood and air.
All right.
And the treatment's the same for both.
Treatment is the same for all of them, yeah.
It's yesterday. I was with Jack, and
Mhm.
we were actually doing a chest needle decompression with someone, and well, he eventually had a broken rib, but no, air came sifting out, so he suspected
Cool.
a hemothorax. Is that right? Like blood?
Yeah.
If
It can be
there is
right.
no air sifting out, could there be a hemothorax?
Yeah.
Because blood
Probably needs to put more in.
is actually floating in the space itself, so the 14 gauge needle wouldn't actually reach that part, could it? Or is that actually blood that is in between the thorax, actually under pressure, so it actually comes spilling out, or
Yeah. There you go. Yeah. It'll
it's under
generally
pressure?
spit out a
Okay.
bit. With a I probably should have put it on there. You generally whack a syringe on the end of it, 20, 30 ml syringe on the end of it, so that if anything does come out, it does sort of collect in a syringe, then squirt up into the air and kill
Yeah.
somebody.
Okay.
in the hospital, don't they have these like tubs that they go into?
In the hospital, we don't do a chest needle decompression. We do we put a chest tube in, which
Okay,
is this,
gotcha.
yeah, underwater seal drainage and stuff like that. It's fun stuff.
Did that on JFK.
Did you?
Not JFK, Reagan.
I was going to say, didn't JFK get shot in the head?
Yeah.
Underwater chest tubing is something air ambulance will be doing too when I get that started. Applications for which are open. Cricothyroidotomy is a surgical procedure in which we create an artificial airway where we can't get an ET tube in or an LMA, generally because there's enough neck trauma that means it's impossible for a tube. It's done by creating a small incision below the Adam's apple in that cricothyroid memory, and then inserting generally 7mm ET tube.
Would you actually cut right into the trachea if you do that?
Yep,
All right.
that's the aim. Cut into the trachea, whack in the tube. Last resort, don't do it for the hell of it.
All right.
It's like a collapse of the airway. You can't get an ET tube in or an LMA, and you have to do that.
Massive oral trauma too.
Did you ever do that?
Have I ever done a cricothyroidotomy?
Yeah.
Once.
All right.
Once. Wasn't pretty. Patient died.
Oh.
Yeah. Well. Patients die all the time.
The red thing is the Adam's apple, right? No, it's actually not. Okay.
No.
That's
No,
how's it called again? The red thing.
The red thing's the thyroid gland.
It creates thingies.
Thyroid hormone.
Creates something. I'm pretty sure. No, whatever.
Okie dokie. Medication administration. There are 6 rights of medication administration. Right patient, right time, right dose, right drug, right clinical indication. Do you guys all understand those?
Yes.
Yes?
Pretty much.
Is there anything you don't understand about it?
Well, 2 of them actually. Right
Go on.
route and right time.
Okay. Right route refers to how the patient receives the drug. So in terms of, should this patient be receiving this drug orally or intravenously? Or orally or rectally? So it's like saying, I made Johnny swallow a Panadol suppository. Paracetamol suppository. That's an incorrect route or route. Right time, you look at timing between drugs. So you sort of shouldn't be giving morphine really, really close together. You want to sort of wait a few minutes to monitor the effects and the breathing rate afterwards.
Alright.
Cool. Here we go. Bioavailability. We chatted about that. Commonly used drugs. Do you want me to go through these, or you guys can sort of read through them?
Which one? Yeah,
page
just, no,
39.
just read through them.
Yeah, so they're all in your PDF. Lidocaine or lidocaine, we sort of use about 1.5 milligrams. It's used for extreme tachycardia. It's used to lower the heart rate during tachycardia. You can also use amiodarone.
Adenosine would be SVT, right?
Yes. Yes. Epinephrine or adrenaline for VF or anaphylactic shock. Generally, it is seen in an EpiPen. It's the most common form of adrenaline. Valium or diazepam uses for seizures or convulsions. Helps relax those skeletal muscles. D50 for low blood sugar. 25 grams, which works to be at 250 milligrams. 250? 2,500. Wait. Ooh, that's bad maths. It generally comes in 250 mils.
Right.
A small 250 ml bag of fluid. For us, anyway. Morphine, 5 to 15 milligrams per patient, used to relieve moderate to severe pain. Vercuronium, paralytic agent. So we use vercuronium in rapid sequence induction. So that's the intubation of a conscious patient who you need to put into a coma. Other drugs you can use, dexamethasone is the one I prefer to use, but vercuronium is an American one.
How long does that coma actually could last? If you put in one dosage?
On a standard dose?
One dose is like 0.10 milligrams. How much minutes?
Depending on your patient's body weight, you're looking at around about 10 minutes.
What about a psych patient that's going nuts?
Haloperidol or midazolam.
I gotcha. This is the same thing, sedative?
It's a sedative, yeah. So vercuronium is not a sedative, it's a paralytic agent. So a patient will still be fully conscious and awake if you give them vercuronium without giving them a relaxant such as midazolam. Prochlorperazine is one of the 3 antiemetics I have on your list. It's also called Semitol. It works on the vomit center in the brain as opposed to your digestive
What is
system.
nausea again?
Vomiting. Illness.
Okay.
Yep.
Well, nausea is you feel like you're gonna throw up. It's that queasy feeling you get in your stomach.
Narcan, very important if you overdose somebody on an opioid such as morphine or heroin. Atropine Who just posted in here? Is that you again, Roy?
I think it's in
Somebody
the
in
main.
the yeah,
the
it was in the main TS chat.
Bastards. Do I want to look at that? Sorry, anyway, atropine is used to reverse bradycardia, or that slow heartbeat. And as we said it before, haloperidol for
User joined your channel.
haloperidol for a psych patient who requires sedation. It's a voice message. Cool. And the final page is administering blood products, generally only carried by your ambulance. But if you want to RP it, make sure you do it properly, because I will tell you off. Only use of patients who have received massive blood loss.
Which product?
Blood products. Blood
Which
loss,
product you talking
massive
about?
blood products.
Alright, okay.
It's like a blood transfusion. You must give them through a clean new cannula. If you've given drugs or fluid through a cannula, put in a new one. You should give plasma and packed cells together. The plasma helps bolster the fluid volume, and the cells help they carry the oxygen and the hemoglobin levels. Also monitor their vital signs while they're having the blood transfusion to look for reactions. If they have reactions such as a spike in the temperature or a spike in their heart rate, rashes and things like that, stop the infusion immediately.
Does the normal ambulance actually carry blood products?
No, doesn't. But if you're with me, I generally RP grabbing some from the fridge before I start a job,
Alright.
particularly if it's a trauma job.
So we RP'ly have it in the fridge.
Yes.
Alright.
Cool. Any questions about the lecture, because that is the end of it?
So quick? Oh, Jesus.
That was about just an hour and a half. Shit.
Oh, wow.
Any questions?
Oh, pretty good.
Nope.
Beautiful. Well, thank you for listening. I shall save my changes. Someone 1 gigabyte of recording. Cool.
Oh, by the way, you should actually save the pictures that were sent in the whole thing.
Yeah, I'm going to actually take them and save them and probably add them where I can.
Stealer.
Beautiful. Did you guys want to do the exam now?
Yeah,
I'll do
sure.
it now.
I'll do it now as well.
Sure.
Roy can go first, of course.
Well, okay, there's 2 exams, partly because... Why have I sent that back to myself? Oh, wrong one. Sorry, I was reading a PM. Back. That's the wrong one. Yeah, that's exams. So it's in 2 parts because I can only do 50 questions per exam.
Alright.
If you want to stop recording now, Jack, you can.
So the whole exam consists of 50 questions.